Hello, and welcome to the University of Washington Cardiometabolic Echo Session 18. I'm Nicole Earhart, one of the adult endocrinologists here at the University of Washington. And today we're excited to welcome Lisa Tannock, who's a lipidologist and adult endocrinologist from the University of Kentucky. And she's going to be talking to us today about beyond the statin, so cholesterol management beyond the statin. We're also excited to have our panelists today, including Lorena Wright, the director of our Latinx Diabetes Clinic and an adult endocrinologist, and Savitha Subramanian, our adult endocrinologist and also a lipid expert here at the University of Washington. So without further ado, go ahead, Lisa.
All right, I have no disclosures. So what we're going to do today is talk a little bit through the guidelines, and particularly the emphasis to recognize those with familial hypercholesterolemia who have an early indication for medication use and are often overlooked. I want to talk about alternative therapies for those who are or report intolerant to statins and are at high cardiovascular risk. And then we'll touch on the indications for PCSK9 inhibitors, ezetimibe, niacin, and some of the other more novel non-statin lipid lowering management. So just to remind you, most of my talk is going to be based on the American Heart, American Cardiology guidelines for lipid lowering therapy, and these were released in 2018. And the guidelines, similar to prior eras of guidelines, recommend that we focus on the four groups who have been most clearly demonstrated to benefit from lipid lowering therapy. So this, of course, is those with clinical atherosclerotic cardiovascular disease, ASCVD, and this includes patients with a history of MI, stroke, but does include things like TIA, acute coronary syndrome, peripheral vascular disease, abdominal aortic aneurysm, and all of the atherosclerotic diseases that we know of. So certainly those with clinical ASCVD are clearly demonstrated to have a benefit and should be treated. Then moving to the patients, we're talking about primary prevention. Those with an LDL above 190 mg per deciliter are clearly at higher risk for cardiovascular disease and should be treated. Patients with diabetes who are between the ages of 40 to 75 years and who have an LDL above 70 mg per deciliter have also been clearly shown to have a benefit and should be treated. On a personal note, please do not regard these age thresholds and LDL thresholds as rigid. These are guidelines to help us manage the patients who are at the highest risk. Then finally, for patients who don't fit into the first three categories, but who have an LDL above 70 mg per deciliter, we are then suggested to run their metabolic parameters through the risk calculator. And if their 10-year risk is calculated at or above 7.5%, then they have clear, robust, randomized controlled trial evidence of benefit, and these patients should be considered for lipid lowering therapy. One of the changes that came back in 2018 compared to prior years was that we should continue to monitor LDL cholesterol levels on therapy to help guide decision-making for addition of more therapy with non-statin medications, and also to ensure that the medications are having our desired effect. So in prior years, it was put them on statins and don't need to worry about it, but then recognizing that that misses a group that need additional therapy and also can miss people who are not responding as expected. The 2018 guidelines do ask us to follow LDL levels periodically to make sure therapy is having our desired goals. Now, there's a lot of other things that also enhance risk that are not captured in those four major groups or in the risk calculator. And the most obvious one is family history. There are very few risk calculators that do include tracking family history just because it's hard to quantify. So obviously, if the patient has first-degree relatives or even second-degree relatives who have had premature cardiovascular disease, you will want to consider that. The presence of metabolic syndrome should be recognized as a risk factor that accelerates cardiovascular disease, as should chronic kidney disease. And we often focus that chronic kidney disease patients are at risk for renal progression and renal complications, but actually the leading cause of death is cardiovascular disease in this population. So please be aware that your CKD patients are at very high risk, and even if they don't fall into the four major groups that we indicate, you may want to consider them for lipid lowering therapy. The one exception is going to be those patients who are already on dialysis. That is a single group that has not been shown to benefit from lipid lowering therapy. They have not been shown to have harm, but they have not been shown to have benefit, and it's probably just too little too late. So that's why we really want everyone to think about their patients with earlier stage chronic kidney disease as candidates for lipid-lowering therapy because all earlier stages of CKD have been shown to have benefit, as have post-transplant patients. For women, you want to take into consideration if they have had a history of preeclampsia or other pregnancy-induced hypertension. There is an emerging evidence that this increases their risk for cardiovascular disease with aging. And also women who go through menopause at a young age, and that's either natural or surgical menopause. And the guidelines at this point say age less than 40, but there's a lot of evidence suggesting that even in the early 40s is considered premature and could be an additional risk factor. We know that atherosclerosis itself is a chronic inflammatory disease, and patients with other chronic inflammatory diseases are at increased risk. The general increased systemic inflammation appears to confer that risk. So be aware of patients who have rheumatoid arthritis, psoriasis, chronic HIV, etc., other chronic inflammatory diseases. And skipping down a few points, those who have elevated high sensitivity CRP, if measured, we're not telling you to measure it, but if it is measured, and when they're not in an acute phase reaction, if their hsCRP is greater than 2, that is an indication that they have chronic inflammation and should be considered as a risk factor that guides decision-making. Certain ethnic groups, such as those with South Asian ancestry, are thought to be at higher risk and should be considered. Triglycerides have been a lot of controversy over the decades, and a lot of the work that was done to address this has been done at UW, but triglycerides elevated, and in this case, they chose 175 mg per deciliter as their threshold, has been shown to be a risk factor and should be considered when making decisions. Elevated lipoprotein a, an LDL-like particle over 50 mg per deciliter is a risk factor and should be considered. And then patients who have reduced ankle-brachial index ratios, that's a sign of peripheral vascular disease and should be considered for additional therapy. So it's not just simply the 4 major groups, but we want to consider with each of our individual patients these other risk factors and help guide therapy. So the 2018 guidelines, of course, continue to emphasize a healthy lifestyle over the lifespan. And I personally spend some time with my patients talking about the concept of LDL years. And so let me take a second. Everyone's aware of smoking and pack years. And someone smokes 1 pack a day for 20 years, that's 20 pack years. But if they smoke 2 packs a day for 10 years, that's also 20 pack years. If they smoke half a pack a day for 40 years, that's 20 pack years. And there's a lot of literature demonstrating that with smoking, it's both the dose, how many packs, as well as the duration that create risk. And I think we have an emerging recognition in the lipids that it is very similar, that it is both the dose or the level of LDL cholesterol times the duration, how many years, how many decades is it elevated for, that confers risk. And so healthy lifestyle has to be over the lifespan. We can't just start it when we're middle-aged adults and starting to think about our own cardiovascular mortality. We really need to build it into our public health. So this is a low-fat diet and healthy exercise. We do want to focus on statins, and statins clearly should be the first-line agent for when we're talking about lipid-lowering therapy. And we have robust clinical trial evidence that the lower the LDL, the greater the risk reduction. So it's no longer just throw them on a statin and ignore it. We really want to pay attention to that LDL proportional to that individual patient's other risk factors. And we know that if we drive that LDL cholesterol down lower, we continue to see benefit. So one of the objectives was to talk about familial hypercholesterolemia, and I'm going to come to that in just a minute, but the reminder that the 2018 guidelines state that if a patient has an LDL over 190 mg per deciliter, they should be treated, period. There is not an age threshold. And so for any of you who see pediatrics, this is often sort of bizarre concept to you, but we know, again, that the life years, the pack years equivalent of LDL exposure, people with high LDL cholesterol from infancy actually can manifest their coronary disease at a very young age. And so the idea is to treat them when it is identified. If you find a patient who has high LDL, screen their family members, so identify those others at risk and treat them. And statins have been studied in pediatrics. They have been studied as children go through puberty, and there has been no adverse outcomes on some of those things that were common fears some years ago. So reminder that LDL above 190 should be an indication for statin therapy. And then the other thing that the 2018 guidelines want us to focus on is use of non-statin lipid-lowering medications in addition to statins for patients at very high risk, or as alternate to statins in patients who cannot tolerate or refuse to tolerate statins. So who are these patients? These are our patients who have multiple ASCVD events or who have one major ASCVD event and high-risk conditions. And the guidelines say we should add a second medication if the LDL remains above 70 on the statin. The recommendation, largely driven by cost effectiveness, is to use ezetimibe as the first line second agent. That sounds weird, but first line second agent, and then PCSK9 inhibitors if needed to achieve that LDL below 70. So let's spend a minute reminding everyone what familial hypercholesterolemia is. And because that's a mouthful, I'm going to say FH. So FH comes as a heterozygous form or a homozygous form. And this is, there's actually at least three different genetic conditions that cause FH. So the original one that Brown and Goldstein described and got Nobel Prize for is a mutations in the LDL receptor, where the LDL receptor is not able to clear LDL particles out of the bloodstream. So the LDL just continues to circulate and doesn't get cleared. So patients can have one abnormal LDL receptor from one parent or both alleles from both parents, and then be heterozygous or homozygous. But what we also know is patients can have mutations in their ApoB, and that is the protein component of LDL that binds to the LDL receptor and gets it cleared. So you can have a problem with the receptor or a problem with the ligand. And either way, the LDL does not get cleared in the circulation. So high LDL circulates in the body, can deposit in the arteries and cause atherosclerosis. And then more recently, we recognize that PCSK9 gain of function mutations can also affect the LDL receptor circling to the cell surface and similarly affect LDL clearance. So those are the three major genetic causes of FH, but clinically they all manifest the same way. If somebody is a homozygote, meaning they have two abnormal alleles, or if they're a compound heterozygote, which means they have maybe one abnormal from one parent and another abnormal from another parent, say the ApoB on one side, the LDL receptor on the other, they will have sky-high LDL levels, even right from birth, so in infancy. The LDL can be up 6 to 8-fold. The total cholesterol can be up above 1,000. The HDL is typically extremely low. And these children can manifest coronary artery disease by age 10. So if, depending on what the genetic mutation is, these patients actually may not respond to medications. It's always worth, if you identify one of these, it's always worth trying a medication first in case they have one of those compound heterozygote features and have some partial response. But unfortunately, if they are truly medication non-responsive, the treatments are LDL apheresis, liver transplantation, or genetic therapy, which of course is still investigational. The reason I have the photograph of the feet on this slide is that a physical exam cue that can point out FH is widening of the Achilles tendons. Now, this image, I just pulled it off the web, I think, or it might be one of my patients from forever ago. I've had this picture forever. It shows bilateral thickening. And if the Achilles tendon is wider than the width of your finger, that is abnormal. In many cases, it's actually more of a nodular thickening, and that's something that you just palpate, you run your fingers down the Achilles tendon, and if you feel a widening or a nodule, that could be a sign they have FH. I will reassure you that if you or your patients have ruptured your Achilles tendons, you can have scar tissue that causes a widening, and that is not necessarily FH. But it's a quick and simple physical exam trick we can use to screen patients for FH. The absence of it does not rule it out. You still want a lipid level. And the presence of it, of course, could be something else like an Achilles tendon rupture, but it's a great little clinical sign that you can help to screen for high-risk patients. All right, familial hypercholesterolemia heterozygotes are patients who have one normal allele and one abnormal allele, whichever genetic situation it is. And depending on what the abnormality is, they may have LDL significantly elevated 2 to 3-fold, but not as high as we see in the homozygotes. Because these patients have usually a normal allele from one parent, they are medication responsive. But collectively, heterozygous FH causes about 4% of premature coronary artery disease. Again, the LDL is elevated from birth, and this is part of the reason that the guidelines want us to recognize any human with an LDL above 190 at any age and consider them for treatment. And of course, if that's the index case, screen their family members because this is genetic, and you will find other patients and we can help prevent the burden of coronary disease. So if untreated, which hopefully is rare, and so this is older data, but there is some older epidemiological studies suggesting that patients with heterozygous FH and the data is mostly in men, 5% will have their cardiac event by age 30, 20% by age 40, and 50% by age 50. So this is really why we want to identify these patients as young as possible, including childhood, and start them on treatment as young as possible. And again, the treatment would be statin as first-line agents. Many of these patients would need additional therapy because they're at such high risk, and ezetimibe, PCSK9 inhibitors can be used. But this is probably the most common question that I get asked as a lipidologist practicing is, what if my patient can't or won't take a statin? And let's keep in mind, there are patients who refuse to try statins, perhaps because they either themselves have had a bad experience or they've heard from a dear friend or loved one that someone else has had a bad experience. And so how do we help manage them? Well, the first thing I want to talk about is true statin intolerance versus symptomatic statin intolerance. So in randomized controlled trials of patients, and there have been literally 100,000 patients studied in trials collectively, the rates of statin adverse effects, including serious muscle injury and including rhabdomyolysis, remain very low at less than 0.1%. Serious hepatotoxicity is so low that we no longer have to screen liver enzymes. And while statins do appear to unmask diabetes, it's about 0.2% per year of treatment, and that is still much lower risk than the benefit we're giving. But in the real world, statin discontinuance for reported statin intolerance is about 10%, so much, much higher than what we see in studies. And given that statins are used or recommended for use in about 25% of adults over the age of 40, this is an enormous public health issue. And so what's the discrepancy? Why do so many patients discontinue statins when the adverse rates in the randomized controlled studies are so low? And this is an ongoing challenge, and we all have these patients in our practice that we want to prescribe a statin, we recommend a statin, and the patient can't or won't take one. So I want to spend just a moment talking about the power of thought. And we all know what the placebo effect is, right? So we know in randomized controlled trials, when a patient is randomized to active treatment or a placebo, almost regardless of what the study is, the placebo group often shows a benefit. And I think the weight loss studies are one of the most powerful evidence of this. So patients are randomized to an active drug or to a placebo, a completely inert substance, and yet the patients lose weight. And these are patients who've never lost weight despite multiple attempts in the past. Well, that is the placebo effect. It is the benefit that is derived from the belief that a therapy is active when it is not. And it really shows the power of thought in many ways. Well, similarly, there is the opposite. There is the nocebo effect. And this is the concept that belief that a therapy is harmful when it is not can lead to harm. And I truly think that this underlies a lot of the patient's complaints about muscle intolerance that we hear so commonly. Despite the fact that in randomized controlled trials, the rates are so low, in the real world, it is so much higher. And the majority of it is muscular complaints, that I think there is a large part of the nocebo effect. And this is a big challenge to overcome for all of us. But I also want to remind us, we have to look at our own contributions as healthcare system providers. So there are a number of different patient populations that have inherent mistrust of the system. And honestly, let's acknowledge some of our historical mistakes and the historical trauma that some of the patients are dealing with. So we also have an element of mistrust and cynicism from some patients towards recommendations. There's the cost. Even though most of these drugs are generic and very cheap, there is still a cost. And for some of the patients, that adds up a lot. And then there's just the impact of insurance changes and provider handoffs and how things get dropped in the communication. And also keep in mind that hyperlipidemia is asymptomatic. There are consequences from hyperlipidemia, such as acute coronary syndromes or pancreatitis from high triglycerides, that are very, very symptomatic. But patients can be walking around with LDL cholesterols of 200 or 300 and not know they are asymptomatic. And so it is hard to motivate patients to take things for something they have no symptoms. And so I look at organizations like American Heart that have done such a fantastic job at educating the public about the dangers of hypertension, which is also asymptomatic until disease consequences occur, and hope that we will continue to educate patients about the risks of hyperlipidemia, even though it's asymptomatic. So what do we do for patients who report statin intolerance? Well, first, let's recognize that there are multiple risk factors for ASCVD, and let's spend a lot of time maximizing control of the other risk factors the best we can. So let's get our patients to quit smoking, let's manage the hypertension, let's control diabetes, all of these other things. But in terms of focusing specifically on the statins, there's several steps that I do in my practice, and many of these work. So the first thing I recommend to a patient is to take a drug holiday, stop their statin, and I often counsel them to keep a symptom diary. I mean, it's 2022, and if you don't have muscular skeletal aches and pains on a daily basis or a periodic basis, then congratulations, you're rare. The world is stressful. We live in stressful times. Many of us have very stressful jobs. The all Zoom world where we're sitting all the time, or the individuals who have, very labor intensive active jobs, we all have muscle aches and pains. So I ask patients to keep a symptom diary of what their symptoms are off the lipid lowering medication. And then I'll restart usually the same statin, and I will usually restart at a low dose, have them continue their symptom diary. And many of them recognize that it really isn't different off and on the drug and will continue it. If they do have more symptoms on the drug, then I will try another drug, and I will try at least 3 different statins. And another trick here is that recognizing that while most statins are metabolized through the CYP3A4 cytochrome P450 system, which is the system that metabolizes about half of all pharmaceutical drugs out there, rosuvastatin and pravastatin are not metabolized through that pathway. And so I will sometimes spend time counseling patients about rosuvastatin or pravastatin, recognizing that pravastatin is a low to moderate intensity drug at best, that runs the risk of decreasing any, polypharmacy drug interactions. And again, working on that power of thought to try to get better tolerance. We also will definitely recommend starting low and titrating. And if patients are keeping a symptom diary, sometimes they can really tell you at what level their symptoms change. And then it is off-label use, but another alternative is to try alternate day or sort of 2 to 3 times a week statins. There are no cardiovascular outcome studies with that method, but there are a number of lipid efficacy studies showing that alternate day statins or even 1 to 2 a week statins actually have good lipid lowering effects. Not obviously as good as daily dose, but still any LDL lowering is better than none, in my opinion. And so I will often have patients try alternate day statins. Another pearl that I recommend is a lot of people are weekend warriors, for want of a better term. They're quite sedentary during the week at their job if they have a desk job, and then often are out in the mountains and hiking and fishing and whatever they're doing on the weekend. And if they complain that their muscle symptoms are so much worse when they're active, then just have them take their statins 5 days a week. I have lots of patients who do that. Or they stop their statin when they go on a hiking vacation, or they don't want to have muscle aches and pains on their cruise. We can certainly start and stop these medications, but collectively over the course of 365 days a year, I try to encourage my patients to take it as much as they can. All right, but then there's beyond statins. So we do have other tools that we can use when statins can't or won't be used. Plus, of course, we're asked to add these non-statin medications for the patients at very high risk. Just to remind you, that's the patients with multiple ASCVD events or one ASCVD event plus high-risk conditions. And if their LDL remains above 70 on maximum tolerated statin, then the recommendation is to add another drug. The cost-effectiveness guidelines do recommend ezetimibe as the first-line agent or PCSK9 inhibitors. And over the next few slides, I'm just going to go over all of these different medications. So to remind you about ezetimibe, this is the drug that works by inhibiting intestinal cholesterol absorption. It's relatively wimpy as monotherapy in that it only drops LDL about 18% in monotherapy in the trials. When you add it to a statin, it actually appears to have more efficacy and can lower LDL up to an additional 25% on top of the statin effect. With monotherapy, musculoskeletal complaints are very rare. And so that's a nice positive thing we can reinforce to patients. And we do have a randomized clinical trial showing that we have decreased cardiovascular events with combination therapy. So ezetimibe plus statin reduced cardiovascular events more than statin alone. So nice evidence to use ezetimibe either as additional therapy or as monotherapy if needed. I threw the bile acid resins in because we often overlook these drugs. They're old and they're not that well tolerated in Western countries, but they are effective. So they work by binding the bile acids and facilitating cholesterol excretion through the GI tract. They can lower LDL up to about 30%, depending on dose. And the reason they're not that well used is due to their GI complaints and side effects, which is reported as up to 30 to 50%. Now, again, there's different cultures that have different tolerance for GI side effects. And so bile acid resins are not used that much in North America, but are used in other countries. I will remind you all that they are contraindicated if triglycerides are over 400 mg per deciliter, and that's because you can get a paradoxical increase in the triglycerides, and the last thing we want to do is cause pancreatitis. And I would say the biggest limitation to them, other than their GI side effects, is that we really don't have any outcome studies proving their efficacy in reducing cardiovascular events. But we have so many outcome studies demonstrating that lowering LDL reduces events. It doesn't seem to matter how you reduce LDL, that I feel very comfortable in extrapolating that if someone is taking bile acid resins and their LDL is going down, that we are providing benefit to reduce their cardiovascular event risk. Then there's the PCSK9 inhibitors. Of course, these are the sort of newest, well, relatively newest class, very, very potent. Again, they increase LDL uptake by increased LDL receptor cycling to the cell surface to clear the LDL from the circulation. They can lower LDL 50 to 60%. Funnily enough, we do see a lot of MSK complaints as they have gained market share and be used more widely, and reports anywhere from 5 to 20% of patients are reporting musculoskeletal complaints, typically patients who have reported a history of statin intolerance. We do have nice randomized controlled trial evidence that the addition of PCSK9 inhibitors to statin lower cardiac events more than statin alone. So we do have robust evidence for their use. Bempedoic acid is really the newest kid on the block in many ways. This is a drug that inhibits cholesterol synthesis. It can lower LDL about 30%. And even though it sort of works upstream of statins in the cholesterol synthesis pathways, but it has to get converted it's taken as a prodrug and has to get converted to active drug. And even though that happens in the liver and not the muscle, we're still seeing musculoskeletal complaints as we start seeing emerging use of this drug. And at this time, we do not have any cardiovascular outcomes. There is a large study called, I think it's the CLEAR trial, I may have the acronym wrong, that is underway. And again, we are comfortable extrapolating from the other robust data we have with statins and other lipid-lowering drugs that lowering LDL reduces events. So that's why it is available. I trained at Seattle, and I think Seattle was one of the favorite places to use niacin, although it has so largely fallen out of favor at this time. But niacin is certainly a drug that has efficacy, although again has largely fallen out of favor. Niacin works by decreasing VLDL synthesis, so it leads to lower LDL and lower triglycerides. You can see LDL drops up to 40% and triglyceride drops up to 30%, depending on the dose of niacin that is achieved. There is, I think still, I see it out there, no flush niacin. No flush niacin is 6 niacin molecules complex together. And rodents, but not humans, can break down no flush niacin into individual niacin. Humans cannot. So no flush niacin in humans does nothing because it just basically passes straight through the human body and is not active. So immediate release niacin or the extended release niacins are the drugs that are efficacious for lipid lowering. But of course, there's a lot of side effects such as GI intolerance, flushing. The flushing is probably the most common complaint. Glucose intolerance, peptic ulcer disease, gout, many of these side effects. And probably most importantly was in a large RCT, randomized controlled trial, there was really minimal evidence of any further benefit of statin plus niacin versus statin alone. So niacin has really fallen out of favor, but that being said, I still have a handful of patients who use niacin and manage the flushing and other symptoms and get the lipid lowering benefit. We do have a very old study, gosh, from like 1960s or something in men showing that niacin did lower lipids and reduce cardiovascular events. So we do have some outcome studies. And then finally, I mentioned icosapent ethyl, which of course is a highly purified fatty acid that it does not lower LDL cholesterol. It lowers triglycerides about 30%. But the reason I mention it is that we do have a randomized controlled trial showing that the addition of icosapent ethyl to statin lowered cardiovascular events more than statin alone. The mechanism for this is probably partly due to its ability to lower triglycerides, and it may also have anti-inflammatory and antioxidative benefits. And then finally, you can start or add diabetes drugs that have cardiovascular benefits, such as our GLP-1 analogs, SGLT2 inhibitors, or even good old-fashioned pioglitazone that has cardiovascular outcome benefits. These drugs mostly are limited right now to patients with diabetes, but we are starting to see expanded indications, and we may continue to see expanded indications even for patients without diabetes. And so finally, my favorite image is this cartoon that I took from the web, but medications that aren't taken don't work. And so I spend a lot of time with my patients revisiting the reason, the rationale to take their medications, again, even when we're treating an asymptomatic disease and with all the costs and other benefit challenges that we talked about before. And thank you.
Thank you so much, Lisa. I think the two things that I learned the most, I love the idea of looking at the LDL, like smoking pack year histories, duration and level. So that's great. And then also, yes, taking the medication is paramount. And I think it's hard when they don't see an immediate effect of the medication. Some of the questions that came up in the chat, and we had a very lively chat actually, was about how do you factor in duration of diabetes, both type 1 and type 2, when you're thinking about initiation of medication therapy for statins?
Yeah, great question. I think there's emerging evidence that duration of diabetes plays a role. And so I look at duration of diabetes, not just the age of the patient. So the guidelines are patients with diabetes age 40 to 75. But if you had someone who manifested type 1 or type 2 in the childhood, that may be too late to start at 40. So we also know from evidence that patients with other diabetes complications, the microvascular complications such as retinopathy, CKD, a little less evidence with neuropathy, those also indicate patients who probably have higher risk. And so in general, we are saying, consider therapy much sooner, consider the collective risk factors, but maybe 20 years of diabetes diagnosis is something to consider rather than waiting until age 40. Now with type 1, that's pretty easy. We know when type 1 starts within a relatively short period of time. And with type 2, keep in mind that unless the patient was getting regular screening, many patients aren't diagnosed with type 2 until they've already had it for 5 or 10 years. And so I try to factor that into my consideration.
Great way of looking at things. Thank you so much. Talk to us a little bit about the moderately elevated LDL, like maybe 130s to 140s to 160s. When are you thinking about therapy initiation? Obviously after lifestyle has been modified, but tell us a little bit more about that discussion, because I think that's the most challenging sometimes with patients.
Yeah, I agree. That is the challenge in patients and probably the most common of what we see across the board. So a huge public health burden. Officially, we are asked to estimate their 10-year risk by plugging those numbers into the risk calculator, and that's built in. You can build it into your EMR, or I have it on my phone as an app. It should be pretty easy to do. And if their 10-year risk is greater than 7.5%, we should strongly recommend therapy. But if you remember the slide I showed with all those other risk enhancing factors, that's who I consider. So if it's, for example, a 50-year-old woman who's been menopausal for 10 years, even though her risk calculator may not calculate her risk to be that high, I know that premature menopause is a risk. If it's a patient with CKD, if it's a patient with high risk ethnicity and or a strong family history. So I really try to look at all of those other factors. And this is the art of medicine, right? This is where we have to individualize therapy, and it's a discussion between us as providers and the patient about what their comfort level is, what their risk is. Depending on insurance, we can also turn to some other tools, such as a coronary artery calcium score. Where I practice here in Kentucky, that is not well supported, and so I don't have that option very frequently. I will sometimes measure a high sensitivity CRP, and if it's elevated, that's another thing I will consider. These are all the tools we have, but we could spend a ridiculous amount of money in diagnostics and testing when a simple conversation right up front with the patient, what's your concern? What's your risk? What do you know happened in your family? And are you willing to try this? Could be a great option. So essentially, it's an individual conversation with each individual.
Great points there. It's all about individualization. And here's another question. Do you ever pull statins off of people once you start them if they really modify their lifestyle and then they have significant improvements in their LDL?
Yeah, so my simple answer is no. And that's because what we know from diet studies, intensive diet studies, is really the most that you can improve LDL cholesterol by diet is about 10%. LDL cholesterol is genetically regulated predominantly, and the amount that we eat is such a minimal contribution. So I really worry that we are not giving patients the medication that they need if we withdraw statins. Now, another question I often get related to that is, well, my patient had an LDL cholesterol in the teens or 20s on their statin. Should I stop it? Is there a danger of going too low? And the simple answer is no. But in that case, I try to go for cost effectiveness. While we know that the lower the LDL is better, I don't know that there's a benefit to being in the teens versus the 50s. And so if I have patients who achieve very low LDLs on their medications, I will go to a much lower dose or move perhaps down to a lower intensity statin, just to help really for financial reasons more than anything else.
And then there was a question about, do you ever not put someone on statins because they only meet criteria by like age, or do you ever hold that statin in someone who doesn't have diabetes or any other metabolic parameters, but they make the risk factor because of age?
Yeah, so basically, thank you, whoever asked that question. You're acknowledging that the biggest driver of the risk calculator is age. And so I don't, but again, it's all about individualization. If age is the risk factor, we know that that's a really strong risk factor. The flip side is I spend more time focusing on the younger age. And so the guidelines often are age 40 and up, and that's pretty much based on who's been studied in these randomized controlled trials. And I actually feel that we as healthcare providers are neglecting high-risk young individuals. And I'm gonna go off on my soapbox for a minute about young women with reproductive age. And so I think there's an incredible bias by many healthcare providers to not put young women in reproductive age on lipid-lowering therapies because of the potential concern that they'll get pregnant and what the statin or other agent could do. So first of all, statins are not approved for pregnancy, and women should be counseled to stop them before pregnancy. But we have like 100, 150 case reports and small group studies of women who inadvertently or intentionally took their statins, at least through conception, if not all the way through pregnancy. And from those reports, there is no increased fetal adverse outcomes compared to women who stopped the statins. And plus, we often will treat young women with ACE inhibitors and ARBs or Accutane and these drugs that are truly teratogenic, and yet we won't give them statins. So I'm spinning that question around and focusing more on the younger group that I think we often miss opportunities to treat.
Got it. And any special considerations in any particular races or cultures that you want to highlight today with statin use?
So I think it's controversial. Let's acknowledge it's very controversial. And the studies we have on races and cultures and ethnicities is driven. There are some flawed studies, and it's also very biased by whether we're looking at whether it is someone from a particular heritage living in the US versus a particular heritage living in their home country. And that's because we're neglecting the impact of diet. And so for example, the diet in Southeast Asia is very different than the diet in US, and yet Southeast Asians are at higher risk. How much of that is environmental, how much of that is genetic, and how much is we don't know. So it's something to consider, but yes, we do want to consider the populations where we have a sense that there's a higher ethnicity risk.
Great points. And Savitha, do you mind just commenting on, there was a question in the chat about just how have you been able to get these medications? Let's focus on our Medicaid population versus commercial insurance regionally, maybe on the PCSK9 inhibitors versus any of the alternatives that you find have been useful.
Yeah, sure. So here in Washington, ezetimibe is widely covered. It's very inexpensive. So if you want to add on to statins, ezetimibe is a good start. PCSK9 inhibitors, so Repatha and Praluent, are actually covered for appropriate individuals under a Washington state Medicaid. So you just have to pick the right patient. So as Dr. Tannock said, people with genetic hypercholesterolemia or people with atherosclerotic cardiovascular disease who are not at LDL goal. If you document appropriately, you can get it for patients. Oftentimes it's, where the prescription is coming from, right? So, if you're a geneticist, you can get genetic testing covered, but as, when I try to order genetic tests, it never gets approved. So similarly, you might want to know, there might be it's primarily, who's prescribing the drug. So if you have a preventionalist who does this a lot, or you have a lipid clinic nearby where you're at. So, like in our clinic, in our lipid clinic, we have very high success rates. So over 98% I'm talking specific for Medicaid population in our state. So yes, you can get it. It is covered. Other drugs like uric acid that's marketed as Nexletol, I can't even get commercial insurances to cover it. It's very hard to get. It's about $10 a pill. And icosapent Vascepa is actually quite hard to get through Medicaid because they want to give generic Lobasa because of the cost. So that's pretty much it. There was a time when fenofibrate was quite expensive. The price went up like maybe a couple of years ago, but you can get it through Medicaid.
That was a great summary, and it just shows that sometimes we have to take a few extra steps, but it is a resource for our patients. So I'm glad that, we'll end on that it is accessible, with a little extra legwork with our patients. So
there's actually one more question.
Yeah, go ahead.
Somebody put in the Q&A. How do you get patients to take icosapent ethyl? Many discontinue due to GI side effects. Lisa?
Yeah, so I like you are struggling to get it approved. I struggle to get it approved. I will tell you my personal bias is while icosapent ethyl has the best randomized controlled trial evidence, and there's lots of debate in the literature and at scientific meetings about why it's better than the EPA DHA combined pills. It does lower triglycerides acutely. I don't tend to get it approved or use it for long-term therapy. I was sharing it more because there is evidence you can do that. I tend to really use fish oil in patients who are at very high risk of triglycerides and need acute lowering. It's one of the more potent ways to lower triglycerides acutely.
Great points there. And we could keep on talking about specifically lipids because there is such great chat questions going on, but we also have a great case to present. So Jessica, go ahead and share Dr. Lee's slide, and Penny, if you want to go ahead and start the discussion and present the case. Thank you.
Oh, hi, I'm Penny Lee. I work at Outpatient Medical Center. So my case is for a patient, 65 years old, history of coronary artery disease, hypertriglyceridemia, hypertension, peripheral arterial disease, and poorly controlled diabetes. So I presented this case to get suggestions on how to better control his blood sugars and his triglycerides. I first met the patient back in January 2022. He mentioned, his summer in 2021, he had 2 long hospitalizations, one for urosepsis due to obstructive kidney stones, and then he was admitted in June 2021 for acute limb ischemia, had a popliteal bypass. He reported, when I met him, he reported a history of prediabetes, so he ordered labs to follow up on his chronic condition. And over my time working with him, we changed his simvastatin to atorvastatin because that was mainly because there was a medication interaction with his amlodipine. He was started on chlorothalidone for kidney stones and also to better control his blood pressure. But when his A1C came back, it was 7.3%. And then, the miracles of Epic, it pulled in a A1C from some years ago that was 12.3%. So it seems like he's had diabetes and for a long time. He was not on any medications. His triglycerides were 406, and LDL was not calculated because of the triglycerides. And at that appointment, I guess when I saw him, he was complaining of intermittent hematuria, which led to this diagnosis of a right-sided staghorn calculus, and that became the main medical focus for the next several months. And eventually did follow up with him back later in the summer 2022. We started on metformin that caused diarrhea. We were going to talk about GLP at his next appointment, but the top priority was to finish the staghorn calculus treatment. His A1C in June was 7.9%, but then his A1C, when it was repeated in 11, it was 12.6%. And I haven't had a chance to talk with him to discuss follow-up with his diabetes since then, but we do have a follow-up appointment later this month. And hopefully we'll be able to focus more on diabetes because I think he's finished his kidney stone treatments and 2 surgeries now. As far as his high cholesterol, so let's see. So he has established with cardiology and vascular. We talked about changing his simvastatin to atorvastatin, and then his triglycerides remain high at 281, and so his atorvastatin was increased, and then he was eventually started on Vascepa. His most recent labs, and this was from October, his triglycerides were 431 with a direct LDL of 92, and then he was recommended to start on ezetimibe. let's see. And I'm also not sure if he's taking his medications regularly, because I know, at least for the metformin, he had ran out of it for a couple of weeks. And I think for this patient, it's really important that we get his diabetes and cholesterol under control, but it's also been hard to coordinate care because he doesn't live in Seattle, and we're trying to do labs through an external lab, but that's where I am right now. Oh, let's see. Do I go through the medical history too?
Yep.
Okay, so other relevant medical history: diabetes, so obesity, his BMI is 36, arterial disease, coronary artery disease, hypertension, hyperlipidemia, current medications, Formin, Visipa, ezetimibe, atorvastatin, lisinopril, metoprolol, amlodipine, chlorthalidone, aspirin, warfarin. I mean, that's for his peripheral arterial disease, tamsulosin, oxybutynin, and sildenafil. He doesn't have any allergies. His mom had diabetes. No, he does have a family history of heart disease. He lives on Whidbey Island. He lives by himself. He is semi-retired since 2009. He worked at a medical center before. He's currently single. No current tobacco use, but has a 27-year pack year history, quit in 99, and then no alcohol since 89. Had 2 drinks a day previously. So his glucose, most recent lab. So the last glucose we have is from May, and it was 133. His A1C was done in November, was 12.6. Creatinine in August was 1.01, and then total cholesterol was 225 done in October. LDL was 92 done in October, and HDL was 34. Triglycerides of 431. His LFTs have been normal. He has +1 protein in his urine. No foot exam, and then he has not been referred to diabetes self-management or nutritional therapy. And then barriers to patient compliance, treatment success, so other complicated medical issue, concerned that he has difficulty adhering to medications. Transportation is an issue, so most of our appointments have been phone appointments, though all his providers are at UW. He's not active on my chart because he does not like to use computer technology, and then difficulty coordinating lab orders with the external lab. I wish I had more clinic access. And he is someone that would benefit from having like a case manager to help him coordinate all of these medical issues too. I don't have any mealtime information for him.
Great summary. One question, has he been monitoring his blood sugars at all? Was he aware of the sudden change of it? Or was this a surprise because he doesn't check his blood sugars?
I think this was a surprise because he wasn't aware he had diabetes.
Got it. And then Savitha, did you have a question, a clarifying question? Go ahead.
Yeah, Penny, thanks for that presentation. Yeah, so doesn't look like he has much social support. Have you seen him in person? So it sounds like you did mostly phone visits.
Yeah, I've seen him once in person so far.
Okay. And anything about does he have like family in the area? Is he any sense of what his home life is?
Let's see. I thought he has.
Is there, lots of stuff going on here.
Yeah, he says he has family in Olympia and Seattle. I don't know if we've done a PHQ study, but I know that I guess the kidney stone, Statin kidney stone, has been just what is his major focus. So we've had appointments, but then they've been canceled because I'm getting my surgery.
Yeah.
Why would I need? Yeah, I was actually surprised that they went through with the surgery with his high A1C. Because that was checked by urology or as part of the surgery workup. Oh, and then the other thing is he probably has undiagnosed sleep apnea, but he's deferring evaluation until the kidney stuff.
So it sounds like a lot of things have come at him in a short period of time.
Yes, exactly.
Okay. And he's home alone. He didn't go to like a skilled nursing or anything. He was discharged home and okay.
Yeah.
And Lorena, did you have any clarifying questions for Penny before we move on to the case discussion?
Yes, so I noticed that his triglycerides are kind of getting worse and worse, and he is on 3 different anti-cholesterol medications. So is he taking the 3 medications as far as we know, or?
Yeah, so that's something I'll have to confirm at his follow-up when I see him. Yeah, because his triglycerides are still have been high, even though, like as you said, he's on 3 medications.
And that that could also be because of his diabetes is poorly controlled and
Interesting.
that was that
Mhm.
better. But I would ask that because sometimes when we add medications and for cholesterol, for example,
Right.
when
Uh-huh.
it's not a face-to-face visit, sometimes they might get confused thinking that, oh, I'm starting this one because, and I'm going to stop the previous
Right.
one. So I would just clarify to make sure that he didn't stop the previous one or something like that.
Thank you.
Great point, Lorena. And we'll let Savitha take it over as our more detailed case discussion. Go ahead and share a slide, Savitha.
Okay, so last case of this. So thank you to Dr. Lee for that presentation. So very quick summary. So we have a 65-year-old who has new diagnosis, at least that's what we think. Maybe not. New diagnosis of diabetes, hypertension, many other comorbid conditions, including severe peripheral arterial disease. He's had two recent hospitalizations for this urolithiasis, and he's also had maybe one or two episodes of UTI with sepsis. He has a high BMI. You see his med list there, and we were just talking about this. This is just his cardiometabolic stuff, and there's more that he's taking beyond this for his bladder issues and the kidney stones. So just keep that in mind. He has a Medicare Advantage plan. He's single, he's partly retired, and we don't know, maybe there's some adherence issues. He lives far away. He, maybe some limited social support. We don't know a lot of things, but you can see his labs. One curiosity I noted was that his A1C was 12, but maybe this was at the same time, the blood glucose, and I'm calling it a random blood glucose, was 133 on the same date, maybe, that his A1C was drawn. So that was, I thought, was interesting. And we know his lipids, his LDL is 92. So keep that in mind. His triglycerides are elevated and his HDL is on the lower side at 34. So as we normally go through, diagnosis, general goals, social determinants of health, diabetes goals, and cardiometabolic goals. And Dr. Lee's specific questions was recommendations for diabetes and lipid, we'll call it cardiovascular risk management. I don't think there's any question this gentleman probably has type 2 diabetes. His metabolic picture is consistent with that. So keeping that in mind, general goals. So for a continued partnership, Dr. Lee has actually done several phone visits. It looks like he's engaged on his phone visits, but he does have other things going on besides his diabetes and lipid issues. But everything with diabetes is a shared partnership, and a multidisciplinary team is absolutely necessary. He has not seen a diabetes educator or dietitian. So if this is a new diagnosis, something to keep in mind is to make sure that this is not forgotten. So education, when his other medical issues are stable, diabetes self-management education or sending him to a diabetes educator for one-on-one visit would be absolutely helpful. And Dr. Lee had mentioned this, but care management would be helpful where you have a nurse who touches base with the patient, but he lives far away, but maybe even phone visits with if your clinic nurse is able to do that and maybe touch base with him and see how he's doing. But the point here is that this is a multidisciplinary, this is a team effort. Nothing is, he might, have a good relationship with you, but always incorporating the team so that you can get the help to help the patient is very important. I think a little bit of exploration about his home situation, his medication affordability, finances, maybe see what his social support is, just exploring that again, because diabetes is a multi-layered, multi-pronged chronic disease condition. And things that happen at home are, we don't really understand. We see the patient 20 minutes, 3, 4, 5 times a year, and that's it. And everything else is self-management. So if you don't have things that are going well for him, he's got other active medical issues, but then also what's going on in the home front. Maybe, when you get him to come in, if you have social work support, that's something to keep in mind. But as you pointed out yourself, as you identified, a case manager would be, for this gentleman. These goals, I want to point out here, it's very important. So we're going to set the UTI and the urolithiasis aside. So I think it's very important to address the patient preferences, because this gentleman's, maybe has some injection hesitancy. He has a preference for oral therapies, as many people do. Nobody wants to take shots all the time. So it's important to keep that in mind and, have an open conversation. And, but if he is hesitant to take injections, it's important. This gentleman's A1C is 12%. Sudden worsening of ANC is what we're presuming this to be. It suggests acute hyperglycemia. So his blood sugars have gone up for whatever reason. Maybe it's the stress of his recent illness. So, there's been some decompensation. I think you want to educate him that oral agents are not going to be effective in lowering glucose levels as effectively as insulin would. Also, you also could point out that, he's got these kidney stone issues going on. And if there are other interventions that are needed, suboptimal diabetes management, hyperglycemia is not a good thing and increases the risk for infection. And he is somebody who's already had UTI with sepsis at least once or twice. So I would gently steer the conversation towards insulin. And many people are they'll eventually come around. And I mean, there are some who are completely resistant, but most of the time with a good open discussion and listening to them is always helpful, is what I think.
I think, Savitha, this idea of shared partnership, and then, with this severe hyperglycemia with A1Cs over 10, and in this case, over 12 in the setting of, an acute illness, definitely we want to think about short-term use of insulin. And I would probably phrase it that way. My goal is your goal, but we need this in the short term to make sure you're safe. And with the expectation that if we're able to change something, that he can come off of the insulin as well. I really do think 50% of what we might find something is with a dietary recall. I was wondering if maybe he was like drinking a lot of cranberry juice or something to avoid his urinary tract infections. And if so, if you could find a sugared beverage or something that really was the rise in glucose control, it's probably just the stress of everything going on. And Lisa in the chat did mention, with such a rapid change, we do want to not forget about the risk for pancreatic cancer. But in his case, hopefully he's had imaging. So if there was a big Goomba in his pancreas, we'd see it. Of course, something small and early we might not see. So all those things. But in this case, what I would do is have that phone visit and then really tangible, try to get him, order the med and say, just pick it up. Bring it to the clinic so we know he at least picks it up, and have the nurse teach the injection with very simple instructions. So, and this would also be, if he's open to technology, getting him a sample of a continuous glucose monitoring device so we could see that change. I think what we want to do is give him physical things in the clinic so there is some reason to come to the clinic, and then we also make sure we can do that teaching and everything. So, and I think you don't necessarily have to be at the visit, but a nursing person that can really support him after you give your recommendations and sort of continue that partnership. So that was a long answer. Sorry, Savitha.
Lorena, how do you approach people who take insulin or are hesitant?
Yeah, because his focus has been these kidney stones, right? So I would say that having better control of his diabetes is going to help quite a bit, with the infection. He will feel better, he will be less dehydrated, and that insulin is the most effective treatment that we have. So then it would be, quickly that he would see the difference. And I would say that it doesn't mean that you will be on insulin forever, but to make you feel better and for better outcomes, this is the quickest thing we have.
Absolutely. Yeah. So being gentle, there's always preconceived notions all these people have, so
well, some of my older patients, they remember the needles from their grandparents or parents, which are much bigger. So I do find visually showing them the needle and the size of it is really helpful as well. So.
Right. So just if you look at the American Diabetes Association guidelines, the consensus statement, one of the indications for insulin is an A1C over 10%. So this gentleman fits the criteria. So yeah, this is, a sudden change in the A1C for whatever reason. So if the patient can come in, he does live far. Whidbey Island is far. It takes effort to get here. So we have to acknowledge that. But maybe we can get him in once or twice a year and, showing him the pens and the needles. And it might take a little bit, but it's a partnership. It's a long-standing relationship. So yeah, being gentle and how do you start? This is again stuff you guys have heard over the last many sessions. Basal insulin analog like glargine, or you could also do NPH, intermediate acting insulin, human insulin. Starting dose could be 10 units flat if you wanted to do it that way. I like to do it that way. Dr. Erhardt likes the weight-based dosing, as you probably know by now. but you can pick either as long as you get some insulin in them. It is, you can give them a titration schedule, and this titration schedule can be done robustly or gently. Again, it depends on the patient. If it's someone who's super hesitant, I'll say do it gently and then bring them back in, or at least do phone check-ins. Your nurse can do it. This is just basics of basal insulin initiation, which most of you are probably familiar with. So what about one of the newer agents? So looking at the GLP-1 receptor agonist, just based on his A1C, none of these drugs that are not insulin are going to work as effectively. At this point, there's some acute hyperglycemic situation going on. But if this gentleman is, wanting to start an oral therapy, and we're thinking of GLP-1 receptor agonists, he would benefit because there are many benefits to these agents, as you've heard over the last many months. The oral version of semaglutide is Rybelsus, and Rybelsus it's the only GLP-1 receptor analog that's available orally, and it's formulated specifically in a certain way with an absorption enhancer called SNAC. And what this does is this makes sure that the semaglutide gets to the stomach. And once it hits the stomach acid, the SNAC protects the stomach acid from breaking it down. And then eventually it will get the part of I think it's the distal part of the stomach where it can get absorbed. And that's how the semaglutide eventually gets into the system. It does not have cardiovascular superiority. It is safe. It is cardiovascular neutral compared to the injectable form, which is marketed as Ozempic, which does have cardiovascular superiority or benefit. The key about Rybelsus is it's once a day dosing. Again, this is all just a refresher from what you've heard before. You have to take it first thing in the morning before the first food with a very small amount of water, no juice, no any other beverages. You don't crush it. It cannot be taken with anything else because of that special formulation, which helps it get absorbed. And dose titration, again, all this is stuff that you're familiar with. 3 is the starting dose, then you bump it up to 7 for 30 days. And if you need additional glycemic control, you can go up to 14. But the best A1C reduction with these agents is 1.25% with Rybelsus. You won't get, so if he's at 12%, this is not going to help you get him down to where you need to be. But we always talk about coverage. This gentleman is, I think, Medicare Advantage plan. I got this off the Novo website, which is the company that makes this. I have no conflict of interest, but they say that it's covered through Medicare Part D, as you can see here, and you can look at the costs here. So maybe it is. I haven't been that successful, but it says it's preferred now. So this might have been a new change. So it's covered on Medicare Part D, Medicaid plans, reportedly covered. I don't know about this, but I don't think the GLP-1 is covered, to be honest, but I pulled this. I just wanted to show what's on the Novo website. So, but reportedly it is. So what about the other new class of drugs, the SGLT2 inhibitors in this particular gentleman? So key thing to remember is the SGLT2 inhibitors are not good glycemic lowering agents. You'll get a 0.6, 0.7% A1C reduction at the most. This is not something you would use in someone who's severely hyperglycemic. Also, you may remember that these are drugs that cause glucose loss in the urine. So in someone with a history of UTI with sepsis, you really have to be super cautious in initiating these drugs. So, well, either way, this is not the first line drug at this point in this gentleman. But in future, if you're going to think about initiating this, you have to keep the UTI with sepsis history in mind. However, the cool piece about these drugs is this is pretty new data. So in the last year, there are 2 papers that have been published, one in 2021 that came from a Dutch group, and then one from the Yale group, Silvio Inzucchi's group, where they've looked at these big databases of all these randomized control trials of SGLT2 inhibitors. The Inzucchi group looked at empagliflozin alone, and they had about 15,000 patients. But SGLT2 inhibitor use actually decreases the risk of nephrolithiasis. How? We don't know, but maybe it alters the level concentration of the lithogenic substances. Most stones have calcium. Some are uric acid stones. There may be increase in calcium excretion that may be beneficial because of the osmotic diuresis. It's really not clear. And this is the data from the Yale group using empagliflozin. The incidence rate ratio is favoring empagliflozin. So if you look here, nephrolithiasis, your urinary tract, it's favoring empagliflozin. So there seems to be a beneficial effect. The Dutch group compared use of SGLT2 inhibitor to GLP-1 receptor agonist and found a significant improvement in stone formation when you used an SGLT2 inhibitor. So that's the cool thing. But in this patient, this is not a drug we'd use now. I just thought I'd throw this out there because it's cool stuff that's just coming out. So we'll probably hear more about from that angle. Cardiometabolic goals. So we're going back to the lipids and all his atherosclerotic cardiovascular disease stuff. So this gentleman already has ASCVD. He has peripheral arterial disease, that he had a FEMPOP bypass, and he has diabetes. He has hypertension. He has a high BMI. So many levels of increased cardiovascular risk. So he is very high ASCVD risk classification, and his lipids are shown there on combination, assuming he is adherent with this combination, as Dr. Wright asked, high intensity atorvastatin, he's on ezetimibe, and he's on icosapent ethyl, let's say max dose. And icosapent ethyl, as someone asked in the chat, you have to take 2 grams twice a day to actually get the benefit. So it is, it's a lots of pills, adds pill burden for sure. And if he was actually able to get it, if it's covered, it's a lot of pills. So, however, his general phenotype actually fits the population of the REDUCE-IT study, which is what showed the benefit of IPE. So he actually he's the right patient type to actually get this kind of medication. Lisa, any thoughts?
No, I agree. I mean, the pill burden is a significant issue as its coverage, but I agree. And getting his triglycerides down will actually help reduce his risk. And as you saw, I think when Dr. Lee showed the case, his LDL has fluctuated up and down on this combination, partly related to his other issues.
So what would be a good goal for him, Lisa?
So I mean, a goal for his LDL for sure is to get less than 70.
Yeah.
But recognizing that you have the confounding factors. If when his triglycerides are high, you've got more VLDL, and it's changing it. So
you're saying that there's more stickiness when he's got high triglycerides. Yeah. So the question, should we target the triglycerides? The answer is yes. Right? Yes, that's what Dr. Tannock is saying. Yes, so that's what I have up there. I learned well from you, Lisa. So yeah, so the point here is triglycerides are a cardiovascular risk factor. So don't forget the triglycerides. Yes, you're doing all the right things to get those triglycerides done. But again, it's you're going to add pills, or, what are you going to do? So do we add more medication in this gentleman? How do we help this guy, get better from, metabolic standpoint? Does he need a PCSK9 inhibitor? If he's taking high intensity statin plus ezetimibe and his LDL is at 92, he would actually qualify. He checks all the boxes. He's very high ASCVD risk, and he would actually get it covered. But it is the monoclonal antibodies are every 2-week injections. So this is in somebody who is hesitant to take injections. There's, discuss. Or would you use fibrates in this gentleman? That's the other question. So he has hypertriglyceridemia. So I'm going to show you some data on the fibrates, and then I'm throw it out to Dr. Tannock and see what she might do. So fibrate trials. So the 2 fibrates that we have in the US are gemfibrozil or fenofibrate. The fibrate trials over the years have been highly inconsistent because of the patient population studied. Most of the trials, especially the early gemfibrozil trials, are all male, as well as the fenofibrate trials, because that's how most of these trial recruitment all mostly recruit men. 70% lipid levels have been all over the place. Treatment regimens are, quite all over the place also. So none of the trials have actually shown any cardiovascular benefit so far, except for a couple of the older monotherapy trials using gemfibrozil in the pre-statin era. So, however, there is a certain patient population who might benefit from fibrates, and these are actually data obtained from post hoc analyses. And if you look at these are looking to your bottom left screen, the Accord Field and several other studies, these dots are all to the left of this one line. And so that means in people with high triglycerides, low HDL, meaning triglycerides greater than 200 or HDL less than 34, there might be a cardiovascular benefit. Additionally, in the recent fibrate trials showed that reduction in retinopathy and albuminuria in patients with diabetes, and these are all in post hoc analyses. So do keep that in mind. So to answer the question, can we actually benefit from this? This is just a curiosity. I thought I'd show this. There was a drug called pemafibrate that was actually being studied. It's used in Japan. It is a specialized kind of fibrate. It's a selective PPAR alpha modulator. We won't get into the details, but this study the data from the study got released, and I think it's published. But all you need to take away from this is when people got pemafibrate versus placebo when treated with statin, these are people with diabetes, both the lines, the blue and the red line, are completely on top of each other. There was no benefit, meaning there was no cardiovascular risk reduction. The study was terminated early. And so targeting triglycerides in people with diabetes with this particular drug did not work. So the study was gone. So this drug will probably not make it into light of day in the US for sure. It's actually marketed in Japan. So before I talk about the final thoughts, so Lisa, would you use a fibrate in this gentleman?
Yeah, given his polypharmacy and who knows what he's able to afford, what's getting covered, and what he's actually able to take, my recommendation actually would be to stop the icosapent ethyl and put on a fenofibrate. And yes, everybody panics about the fibrate statin combinations, but really in the studies, other than a statin that's long gone combined with gemfibrozil, really we haven't seen increased adverse outcomes. So I would be tempted to add a fenofibrate, continue the ezetimibe and statin.
I 100% agree, because that's what I was going to recommend also. So simplify his regimen. I was actually going to go one step further. So a fenofibrate actually has a 20% LDL lowering capability. So you may be able to drop his LDL. I might even say stop his ezetimibe and maybe reintroduce it later. So just with the goal of simplifying his regimen. So if you can drop one more pill, you're going to take away 4 icosapent ethyls, statin plus fenofibrate. One thing I do, and I'm curious about what Lisa's practice is, but I actually don't use high dose atorvastatin with fenofibrate. I actually drop it, but that's just my clinical preference, just because of, again, it's completely anecdotal, but I don't use the highest intensity of atorvastatin. I might drop it to 40, but again, that's my personal practice. It's not data driven. It's just, clinically driven. So that's what I would do with the lipids. Now, one point I did want to point out, so there's actually data on this, but rosuvastatin might lower triglycerides a little bit better than any of the other statins around. So I do use a lot of Rosuva with fenofibrate in my. Do you have to do this? No, you don't. You've already switched from Simva to Atorva, but it is something to keep in mind if you don't get. But if you're going to add fenofibrate, you'll probably get a good effect anyway. So that's with his lipids. With his diabetes, I mean, as we talked about, I would probably just coax him and try to make him consider insulin injections. And then eventually, once he comes down and he's monitoring a little bit more and checking his blood sugars, and you get your team involved in his care, maybe he can come off insulin and he can go on metformin and an oral GLP-1 receptor agonist, assuming it's covered. So yeah, so that's pretty much all I had, and we can open it up for questions, thoughts.
Can I make another comment on the insulin? So if his A1C is 12, he's got polyuria and polydipsia, blurred vision. He's not sleeping through the night. He's got all these other symptoms of the hyperglycemia. And I have had patients who are resistant to insulin actually thank me once it started. And so I often spin that forward as a positive tale. And then the other thing, I guess, is Nicole and I put in the chat, both of us probably would be tempted to do premix insulin at an A1C of 12 rather than basal only. And while premix is not ideal, if someone eats fairly consistent meals at consistent times a day, you're getting daytime coverage as well. And with an A1C above 12, that would be my preference. And that might be the single best way of getting those triglycerides down.
That's what I was going to say as a diabetologist. Could we maybe not do the fenofibrate, but use it as an indication, use the insulin as another indication to help the triglycerides, and then limit his pharmacy a little bit and then add it back if needed, just because I didn't see his triglycerides were above 500. So in the short term, we don't want to give him a pancreatitis, but maybe that we could limit his pharmacy a little bit more. And then, I would do a 0.2 to 0.3 units per kilogram dose if we're just going to do basal insulin, because we want him to see a effect. We're not worried about hypoglycemia very much so with that dose. And I actually feel like I would add on the Rybelsus as long as he doesn't have any nausea at baseline from the kidney stones, with the idea that then we can de-escalate the insulin if we're able to. And this will be a shared partnership when we're talking about his nutrition and his activity, because as the Rybelsus goes up, hopefully we can taper it off, and then he'll have a clear expectation. And again, we want him to come in the clinic so he can do this. If he can get a continuous glucose monitoring to see this change, that would be great. It won't be covered unless he's on more than 3 shots of insulin a day, but this would be where you could use a pro or use a sample as well. And I think visualizing it, because this is a huge change for him. He can't see what is going on with his blood sugars, that will be best. And I agree. I often use mixed insulin with the GLP-1s, as we've talked about in other cases. And I think ultimately, unless he does change his nutrition and get a little weight loss, he'll need the mixed insulin or some prandial component. I was really thinking he was a candidate for PCSK9 inhibitors as well, if the every 2 weeks injections were not, a barrier for him, given his preference for non-injections, just because as well of his significant severe comorbidities with his peripheral vascular disease and coronary artery disease. So I don't know, would you guys advocate for it? I mean, would you really have a strong discussion with him as a lipidologist about that?
Yeah, I would. I do think he needs it, especially with his peripheral artery disease and all his other risk factors. Yes. But I think in the immediate term, I think focusing on the diabetes is probably reasonable, and premixed insulin sounds good. Yeah, and once his diabetes gets better, as Marina pointed out and Lisa's pointed out, the triglycerides may come down. They may not, but they might. You just have to wait and see. So none of this you can do all of this in steps. You don't have to throw everything at him at once, right? So it's always a shared decision.
So on that shared decision making, because as always, we're out of time because of our great discussions, we will say this ends session 18 of the Cardiometabolic Echo. Thank you. Bye.